Well, thanks for joining, Vizient members. We really appreciate this opportunity to talk to you about a real need across the United States. Signet Health is the sole strategic business partner with Vizient for behavioral health and for acute physical rehab. And today we put together a short presentation on something we're hearing all the time out in the field, the need for children and adolescent mental health services. Joy Figarski, our president and COO, is on the call. And Tracy Wilson, Vice President Clinical Services, is also on the call. I'm Pat Doyle I'm over business development for the company. So I'll let Joy start us off with a little about Signet.
Again, thank you to all the Vizient partners. We really appreciate the opportunity to talk with you about this, a really important issue, something near and dear to my heart. A little bit about who we are first. So Signet Health is the sole strategic business partner for Vizient for both acute physical rehabilitation as well as behavioral health. I'm very proud to say that we're privately held, we're family owned. It's why I joined the company over 8 years ago. We were founded in 1999 by Jerry Browder, and the Browder family still owns 100% of the company. I think the other thing that makes us unique, which is extremely important when serving the vulnerable, is we're very mission driven. Our mission truly is to advocate for the vulnerable when they cannot advocate for themselves. And I certainly would put children and adolescents right up there in that. We partner with over 70 hospitals, and I think today it's actually a little more than 26 states, but we like to be conservative about that. We have everything from partnering with programs within hospitals, med-surg hospitals, to do joint venture building opportunities, and that's true for both behavioral health and physical rehab. I'm really proud to say, but I say this very, very cautiously, because every day is a new day in healthcare. For all of us, we have never had to pay a settlement for any kind of governmental agency or investigation. Because we are family owned, we can be very flexible. When the tragedy happened in Uvalde, I didn't have to go through layers of people to ask permission. Over the course of a weekend, we put together a team of 7 master's level people who flew in and spent the week there on our expense to support that community and working through that tragedy. Next slide, please. You know, when we talk about children and adolescents and just the absolute crisis going on in this country, there have been some national organizations that have really weighed in recently. The American Academy of Pediatrics took an unprecedented action recently and declared a state of emergency in child and adolescent mental health. It really is a second pandemic, and I think we're just seeing the beginning of it after COVID. The APA, which is the American Psychiatric Association, took a strong position statement, which included some of the following: really, that efforts really need to be focused on increasing current inpatient access for behavioral health and to help improve financial sustainability of existing inpatient programs. And that is exactly what we do. To take responsibility for admissions, medications, therapy, and discharge planning, what that next phase is going to be for a child. And knowing that they're best served by child and adolescent psychiatric providers, and there's such a small number of them throughout the country, especially in rural communities. Clearly, when possible, if you have to hospitalize a child, which is always a traumatic event within itself, it should really be as close to the family as possible for involvement in treatment. Next slide, and to you, Tracy.
Yes, hi. The community need for behavioral health services for children has risen dramatically in the past 2 years. The CDC shows that 1 in 5 children or adolescents have a mental, emotional, or behavioral disorder, but only 20% receive care. And less than 50% of children who have a certified behavioral health condition, which means they've been properly diagnosed, receive treatment. So you're looking at a very underserved population. Next slide. ED visits for mental health increased 24% for children 5 to 11, which is a very, very young age. And again, 31% between March of 2020 and October of 2020 during the pandemic for those 12 and up when compared to 2019 statistics. ED boarding has become very difficult for many hospitals in many regions. In Massachusetts alone, in January of 2021, they had over 300 children who are having to stay in the ED, awaiting beds. That can go weeks, and there actually have been some cases in some states of going more than a few months. Sometimes that's children with some special needs, but sometimes it's just lack of bed space. It is estimated that 20,000 kids in the US lost a parent or a guardian during COVID. So you add that into an adverse childhood experience. That's a great loss for these kids who are also suffering with isolation and other issues due to the pandemic. Next slide. And as we spoke previously, an adverse childhood event has a great deal to do with mental health, emotional, and behavioral problems. Those can be violence, it can be abuse, either domestic violence, or it can be abuse of the child themselves. It can be a death, it can be witnessing something very traumatic, being in a disaster, or growing up with a family member who has a mental health issue or a substance abuse issue, usually that is untreated. So 1 in 6 adults have experienced 4 or more adverse childhood events, which means they've experienced a great deal of trauma in their life. The more adverse events you encounter, the more trauma you have experienced. 5 of 10 of the leading causes of death are associated with adverse childhood experiences. And believe it or not, asthma, diabetes, cancer, as well as suicide are associated with adverse childhood events. 44% estimated a reduction in depression by preventing adverse childhood events. So there is research that says that if we can prevent these from occurring, we can lower the risk of depression. But as we stated further, if you lower your ACEs, you can also lower the risk for asthma, diabetes, cancer, and you can stop those adverse childhood events from being passed on from generation to generation. Next slide. So here are some statistics. 15 out of 100 of children have experienced a major depressive episode. It's 15 out of 100. 36.7 have persistent feelings of sadness or hopelessness. They seem to lack purpose. Sometimes they're isolated. Their support system has disappeared. Almost 19% have seriously considered suicide. They've thought about it. They've thought about what they might do. 15.7 made an actual plan, actually went and planned out what they were going to do. And 9% actually attempted suicide. Now, of that 9%, 2.5% made a suicide attempt that required medical treatment. That's usually overdose, maybe a hanging event, maybe a missed firearm event, but it did require medical treatment. That's 3 out of 100 children today. Next slide.
So when we look at gaps in the continuum of care and we talk about what children need at different points when they're suffering, some of the things that have been identified on a national level is that there's really not enough inpatient beds for children and adolescents in most places in the country. We also know that school is a huge source of not only referrals, but also a stressor, especially at this time coming back into school for many students from COVID. And we know that many students have also experienced a decrease in their scholastic functioning during this period, and that's been documented. What we need is earlier intervention for children in schools and in other places in the community to try and avoid needing a higher level of care. We know that there's a real gap of lack of mental health services in pediatrician and primary care offices. And this is really important because, as we know, it's no different than any other age group. That's where people most feel comfortable going. There's no stigma attached. We all go to the pediatrician, we all go, or most of us go, we're family practitioners for the flu or for this or for that. And that's a huge opportunity as well as a really large gap. We know that there's a lack of specialized staff and leadership to provide the continuum, both in institutions like schools, but also out in the community. I had a conversation yesterday in a specific state, and they're really pushing there legislatively for non-independently licensed clinicians to be able to serve Medicaid, because so many children have that. And there's just a lack of not only of doctors, but a lack of master's level clinicians in most part of the country right now. As Tracy mentioned before, we have the serious problem of boarding in emergency departments, a real lack of pediatric beds, and kids wind up staying in a med-surg bed or in an emergency department for days and days and much longer, and it just exacerbates the problem. Next slide. So when we look at some of the components of things that are being developed and some pilots and models around the country, a lot of times I see pieces, but there's still usually gaps. And if you think about it like anything else, a child, one thing that is happening in certain locations is behavioral health urgent care centers, not only for children, but for all ages. So where somebody can go when they're in crisis, and a lot of times that crisis can be dealt with, and then they can be triaged to a lesser level of care instead of to an inpatient bed by stabilizing that immediate crisis. That's a really important gap and opportunity in a lot of communities. Pediatric psychiatric emergency departments specific that are safe, that have the resources, that have the case managers, that intensive care management involving the families, involving the other providers that have been treating those children. Obviously, acute hospital care, there's always going to be a place for that. I'm a big believer in the least restrictive level of care, always, but there's always going to be a place to keep a child safe when they're in their most acute stay. And Pat and I have been talking to some hospitals in different places recently, where they have children just being boarded in their emergency departments, and just a huge gap of inpatient safe beds for children to go to when they're in an acute psychiatric, crisis. Children's hospitals, often in a rural area. I live in a fairly rural state, and I remember running children's health clinic years ago. And if a kid had more than tonsillitis, they would be helicoptered down to the one children's hospital. Now we have two, luckily, but there was one at the time. And seriously, anything more than what I would call a fairly normal, regular medical or psychiatric event, those kids would be on a helicopter, headed down to the capital city and to the specialized children's hospital. And that's true in many, many rural parts of our country. There's a real opportunity for outpatient services. We have a bunch of initials up here because in behavioral health, we love initials. But really what you're talking about is different levels of day programming, where kids are in a structured program for a certain amount of hours a day, receiving intensified services, but then going home at night. And that can be a wonderful step down from a more acute level of care, but it also can be an entry into the system, and a lot of times avoid needing a higher level of care if you can catch it, especially early enough. Behavioral health integration, which is something really near and dear to my heart, it's what it really means is embedding behavioral health in different ways into primary care and pediatric offices. Again, we know a couple of things. We know there's a huge lack of psychiatric providers in most parts of the country. We know that people feel most comfortable going to their pediatricians or primary care offices. And so it's the perfect place. And we know that often mental health problems really overwhelm those offices, the office managers, the nurses, the providers, in terms of the level of what's needed to help the problem. And so embedding a psychiatric provider, a doctor, an APRN, it can be by telehealth. So it can be really efficient. We have some providers who are doing telehealth to up to 13 clinics in a rural area. And then sometimes master's level clinicians, whether face-to-face or by telehealth. And where I've seen that done well, it's just, a great approach to whole person care and meeting people where they are, and then also taking the stress off of the medical community and allowing specialists to provide assistance. Residential treatment centers, sometimes kids wind up in them, and the average length of stay in most states tends to be about 3 months, which is a long time. I can actually name a couple of states, I won't name them, but where I know the average length of stay is up to 6 months. So that's where kids wind up, less acute than an acute hospital, a little less staff, but they're in school and they're in a safe facility for a pretty long period of time. And of course, then outpatient, obviously FITS has a huge role in this continuum. Next page, please. So what we all hope is that acute inpatient is only used as a last resort to keep a child safe or to keep others safe around them when something else is not available or appropriate at that time. And hopefully it's for a very short period of time. So there needs to be really focus on expanding those community resources. So when that kid is done with inpatient care in 10 days, that they have somewhere to go, and that they have services that will help them stay healthy. Much more of a focus on prevention and early intervention. We see a lot of this popping up in communities all over the country. One big one now is mental health first aid. It's really focusing on identifying, helping non-professionals identify kids or adults, but we're talking about kids right now, some of those early signs before something tragic happens, either to themselves or to a group of other people when a kid is suffering. And I see huge opportunity for that still. And obviously those things need to be funded. There are some federal grants, there's, some monies available, different states, but we have a long ways to go. And often hospitals are in a place where a lot of times you're the community center. You're where people go for all of their medical needs, but also a lot of times other things, whether it's a community health day, a lot of times people identify with your hospitals as places where they feel comfortable and gravitate towards. Services have to be accessible, and we need to be linguistically and culturally in tune and sensitive. And that's a really big deal. I work in a rural state where there are certain pockets of communities that are non-English speaking, and it's a real struggle to be able to get staff, not through interpreters, that can serve those communities. Allowing for more fluid movement between levels of care so that kids can get what they need, where they need it. I know I worked in a state where I was mental health commissioner, and one of the things we really worked on was trying to work on the next point was, how do you share assessment screenings? How do you share records across systems? And obviously you all are sitting in hospitals, so we have a long way to go in that realm, in terms of where we are of care really following the patient and people having better access. So an assessment doesn't have to be done 6 times. And not only is that expensive, but it puts the family through something they don't need to go through. And really doing better linkages of providers throughout the continuum, so people are not seen as competitors and are communicating and working better. Next slide, please. Tracy.
Well, if you look at the monthly average of psychiatric admissions for children versus adults, you'll see that in the beginnings of the year. Now, this was also mostly done right before COVID at that point, but the children are correlated with their lower admissions are during the summer when they're not in school. And there's no one kind of identifying and being able to refer those children very quickly into care. And then again, it begins to drop off in the holiday season at that point. Whereas adults have more of a drop off also at the end of the year and holiday season, but in March. Maybe that's spring, maybe that's change in seasons, but they begin to do that, but they tend to peak out in January, whereas the children tend to peak out in October and November. Next slide. The benefits of inpatient acute psychiatric care is that we're dealing with the acute crisis issue then. You can have some in-depth evaluation by a clinically expert team, and it's not readily available in many service areas. You often have access to a child or adolescent psychiatrist, which is very important, either through in-person or telehealth. It's treated with a short length of stay, about 5 to 10 days, and can be referred to continuum of care resources or upstream. You access resources on the regional basis so families can participate more readily. You'd like the family to be involved and not have to drive many, many hours. You can do that also through behavioral health integration in a primary care clinic, and also through telehealth as well. Next slide. Youth also have some specific needs that may make it hard for them to get the care that they need. Autism is definitely an issue. Any developmental disabilities on that spectrum. Co-occurring substance abuse also is something that has to be considered. The needs of the LGBTQ+ community are also beginning to develop in the child and adolescent years. You have youth from impoverished backgrounds. You have youth who are impacted by structural racism, and you also have co-occurring medical disorders. Sometimes these issues can make it hard to find inpatient care, hard to find placement. People feel that they may not be able to meet their needs. And you also have a group of youth who also have some sexual behavioral problems, which make that even more difficult for them. So inpatient can also help provide warm handoffs to aftercare and home. It's really important in some facilities, one that I'm working at now, after people finish inpatient, they can actually walk them and their family down into the partial or IOP, introduce them to the staff. You know, they can see what it's like and what's going to happen, and they can use some of the assessments that have already been done and pieces and parts of them and just verify differences. Transition services are very important. You need support during the week following hospitalization, which tends to be the week most likely for another crisis to occur. Suicide attempts are at a much higher rate, 7 days through 7 days of hospitalization. So having the case managers, having some bridge services are very, very important. Coordination and collaboration with outpatient clinicians and others at the lower level of care, making sure they know the needs of the family or the patient, and using case management as quickly as possible to also bring in some other kind of services. Often you have people with co-occurring medical disorders who are having problems paying for their prescriptions. You know, they need some home care, they need some durable medical equipment, you know, they need some home health. Those are all very important in that. Next slide, please. Funding sources. There are a variety of funding sources, and each state often has been recently legislating more funding for child and adolescent mental health services. You have state funding. There are many block grants that can be utilized as well. Also, Medicaid has different funding. Basically, there is some funding for residential treatment centers for the schools that they can use and become part of. And there's also the Children's Health Insurance Program, or the CHIP program through Medicaid. Some hospitals can share in disproportionate share funds for reimbursement for taking people who may or may not have Medicaid and are lower income. There's also often private insurance. But to look at some stats, the number of Medicaid children hospitalized between 2008 and 2011, and this is way before COVID, increased from 3.2% to 5.2%. So it increased 2%. That's across the nation. The other thing that occurred was the mean expense for caring for these children in inpatient dropped from $11,000 to about $4,800 because the length of stays became lower. That was because a lot of private insurance and other people were deciding that children could be stepped down to a lower level of care, which some areas don't have that many, don't have a lot of lower level of care to be stepped down to. So the lower length of stays, the managed care impact created an increase in wraparound services, additional residential and multi-system therapy all helped with this issue. But as we deal with money, as we deal with funding, and as people try to create new programs, all of those things need to be considered in each state. Next slide.
Tracy, we are seeing hospitals accessing in states the American Rescue Plan Act, ARPA, that came about through COVID. And there were 2 articles this week, 15 million apiece going towards helping build new facilities. And I know Ohio has made a lot of grants to the children's hospitals up there.
They have, and one of the children's hospitals I'm working at in Ohio is building a pavilion next to their hospital, but that is running about $108 million at the moment. So they've had to put a lot of different funding together to be able to make that project, but they've been very successful. Next
Joy,
slide, please.
Yes, absolutely. And I just want to add, I mean, when Tracy was talking a lot of the wraparound services, a lot of states have been very successful and creative about accessing different federal waivers, 1915I, which is one I worked on, and other things to help provide funding for some of what I would call those non-traditional wraparound services, which can do a great job both as a step down. So recruitment of staff, for any of you who are on from partner hospitals with Vizient, we know that recruiting staff these days is first and foremost a huge worry, a huge headache. A lot of hospitals are capping census in lots of different areas of the hospital because of a lack of staff. And so we know in, behavioral health, there are certain requirements. We need to have a behavioral health director. That's something in our programs that we take responsibility to recruit, to hire. We need psychiatric providers. That's the second thing we take responsibility for. So by partnering together, we bring in a lot of specialized resources to help recruit nurse managers, nurses, therapists. That's becoming extremely difficult in many communities today. We used to, it's interesting, we have a recruiting department. They specialize in physical rehab and behavioral health. And they used to really just recruit our staff. And now we find that hospitals are struggling to just recruit nursing staff. And so we've pitched in, and with most of our partners now are not only recruiting for the Signet staff, but we're recruiting for hospital staff as well, and then trying to retain and provide support to those staff so that they want to stay working in the hospitals. Next slide.
Yeah, I'll take this slide. When we're working with hospitals, a lot of the interest in trying to provide these services are coming from the community partners. The school systems are reaching out, saying they need help. Court systems. I attended a meeting in the Midwest at a sheriff's office. There were about 40 stakeholders, behavioral health stakeholders that came there. And I went as an invited guest with a large not-for-profit religious hospital who happens to have residential and acute child adolescent services, who we now work with. And they were so thankful for this hospital system to be able to take these kids and really not have the jail system try to substitute for the mental health. So we're also finding a lot of interest by children's hospitals, many of which have 0 inpatient beds, and they're seeing many of these kids every day, and they're trying to figure out what to do. And we think there are things we can do to help them. Next. So Signet also offers, besides if the hospital's interested in starting a new small child adolescent program, we recently, Joy and I were up in Maine in a very rural location where we've added a 7-bed adolescent program as part of a bigger, overall picture program. And it's going to serve a 200-mile region. And so we can do small programs. And if a hospital already has behavioral health, but they want to add adolescent, they want to add geropsychiatry, a variety of things, we can actually add a new building and help provide the capital for that. Next. And this is just an example. We have spent a lot of time and effort, if it's a bigger project where there could be adult needed, PICU, dual diagnosis, geropsych, adolescent. You could have 4 or 5 different subspecialties, and we have a hospital designed for behavioral health that can accommodate all these things, and it'll allow you to free up space in your med-surg hospital if you have a unit. But once again, if it's a very small program and you're trying to add to the region, that's something we can look at. And clearly Cigna can try to analyze what the need is in your region, in your community for you. Next slide. So if there's any questions at this time, we appreciate your attention and time today. We'll open it up for any potential questions.
Yeah, Pat, we do actually have a few questions that some people have submitted. The first one that came in was, what would be the relative size of an inpatient unit would we need to offer this kind of service for it to make financial sense?
Yeah, usually we're looking, if it's trying to stand alone by itself, 10 to 12 beds, but it could even be smaller if it's part of a larger project. Joy, your thoughts?
Sure. I completely agree with Pat. The one thing I will say operationally, and for any of you hospital administrators who are on the phone will probably resonate with this, just like any unit. We just we have a brand new program that I think 7 beds, actually 7-bed child adolescent unit. And we can do a really great job managing that. It doesn't become so efficient, to be very honest, because there's certain things you need for a unit. So you start to become a little bit more efficient when you start getting to like 11 and 12 beds. But we operate programs that are 24 beds. We operate a program that's 7 beds and lots in between.
Okay. Next question is, someone asked, how can I tell if or determine if there's a demand in my region for a service area or my service area to support such a unit or service?
Joy, go ahead.
Oh, sure. I was gonna actually let Pat take this one, but I'm happy to. So we do this all the time. Pat and I work very closely together to do what we would call a bed demand analysis. We're pretty conservative because I'm the one who has to face a hospital CEO or CFO or CNO a year and a half down the road. And so we look at the bed cohort of, a certain bed cohort of how many, based on national standards you would have for every sort of, 100,000 people. But then we also look at all the competition. So we do mapping to look at, now I will say for child and adolescent behavioral health, my experience, and I'm sure Tracy can pipe in on this over the years, has been that patients tend to come from much, much farther than what I would call the service area of the hospital because of a lack of beds. So when we have programs where patients come from all over the state, and so we look at, and we draw, circles around looking at all the competition, the population of that age group, and then again, really start to look at what I would call secondary markets, because for child and adolescent beds, it's very, very common that the kiddos will come from pretty far. Pat, do you have anything you want to add?
Oh, and sometimes they even come from other states.
Yes, that's true.
Yeah, and we'll look at the payer mix in the area, the managed care penetration, whether it's Medicaid expansion state, where state boundary lines are, just the referral patterns in the area, if you're part of a system, not part of a system, all those things will enter in along with the population psychographics.
And another question, what do you think the expected, or what do you see as the expected length of stay on child adolescent inpatient acute units?
Tracy, you want to take that?
Yes, it does range. And the averages, if you're looking at it across the board and looking at some of the top 10 hospitals, it kind of runs from 5 to 10. There are some hospitals that run 2 to 3 weeks, but their program is very specific and different. I have seen a children's hospital in Ohio that it runs 4 days, but they have a full continuum of care to be able to wrap around that child and be able to they're still in care, and they're not left alone. So that does make a difference in that length of stay.
Got a question about recruitment. What exactly does Signet do to help on recruiting child and adolescent psychiatric providers?
Gosh, everything and anything. Seriously, I mean, I don't pretend that I have a magic bus. I wish I did, and I've said that to hospital CEOs. So I say it very humbly, but because we specialize, because we have relationships. So for example, we have a fabulous chief medical officer who was the chief of psychiatry at an academic medical center for many years. He also started telehealth in that state before anybody was doing telehealth. So, we use all the what I would call regular recruiting tools that people use, but we also have years and years and years of relationships with psychiatric providers that have relationships with other ones, and that helps. I mean, that's often how we'll go about it.
Okay. Someone asked about inpatient child adolescent programs accepting autistic and developmentally disabled children.
Sure, I'll take that one. So if you're going to be licensed as an acute inpatient bed, whether in a freestanding, and this goes true whether it's in a freestanding behavioral health building, a pavilion of a hospital, or a unit inside one of your hospitals, you have to have a primary psychiatric diagnosis. So you can have a child who has some level of, autism, of a pervasive developmental disorder, which is typically what it tends to be called now. You'll hear PDD, and or developmental disability, but you still have to be able to medically prove that that child meets medical necessity for that acute psychiatric disorder, and that the developmental disability is not why they're being hospitalized. It's actually a similar conversation that you'd have with an older adult person who might suffer from dementia, and they can have dementia, but for them to be admitted to a psychiatric unit, they still have to have a primary problem that can be treated. So hopefully that answers that. And I know it makes it complicated, but we also have, in our programs anyway, we put a big focus on working with the community. We have a position we actually call community education coordinator, because we live and breathe this and most other people don't. And so a lot of it is working together with community providers, physician offices, and all those other bridging agencies, to help somebody understand, well, this kid is causing a huge problem, but is this really the right unit for him? And that's a lot of education and working in partnership, and then sometimes helping place a kid somewhere else if we're not the right place. Hopefully that answered.
Last question, kind of a approximation. What portion of the admissions do you see for children aged 13 to 7 versus those under 10?
13 to 17, you mean?
Yeah,
Yeah.
13 to 17.
The sad thing is it's really changing. And again, some of the statistics Tracy went over, I don't have an exact statistic, Tracy might, but I can tell you that historically, you tended to see much more of teenagers getting admitted, much less so of certainly, a younger child. Unfortunately, the problems, the suicide attempts, serious psychiatric problems, and we see that in a lot of the data that we went back over, is the ages are creeping down. And so that's that if you looked at it on a graph chart, unfortunately, and it's not a happy thing, that number is going this way towards younger kids at this point. I would still say it's not 50-50, but it clearly is in a downward curve with younger children suffering, which is awful.
Well, that's all our questions for today. I'll turn it over back to Pat or Joy, whoever wants to close out for us.
Yeah, I'll close out. And once again, we're very appreciative of Vizient and Kathy Sunderland for helping set this up with us. This will be recorded and available on Signet's website, on Vizient's website. If there's anyone who missed the actual webinar, but looks at the information, has any questions of Signet, please contact me at the information there, the location, email, or phone number. And once again, we appreciate your time and consideration today.